Good morning, and thank you for the opportunity to speak today on Escala Wi-Fi para categorización de riesgo en EAO. I have no disclosures. As we're all familiar, the presentation of peripheral artery disease encompasses a very wide spectrum. Patients at the most mild of disease may have merely just pain or some achiness with ambulation. Next, claudication can set in, including mild to moderate lifestyle limitation. And then finally, we speak of limb-threatening ischemia being categories of rest pain, poor wound healing, or even impending or overt gangrene. Critical limb ischemia, now known as chronic limb-threatening ischemia, which we'll get into eventually, was first identified as a clinical entity in 1982. Initial classification systems did not include patients with diabetes, which at the time was a very small subset, and it was generally agreed that diabetic patients who have a varied clinical picture of neuropathy, ischemia, and sepsis make definition even more difficult, and it was important to just exclude these patients at the point in time. Over time, the Rutherford and Fontaine systems were developed, and these further stratified patients. These systems included asymptomatic PAD as well as intermittent claudication. They differentiated ischemic rest pain and tissue loss as well. And these were the resultant classification systems, with the Fontaine system having 4 stages and the Rutherford classification having 6. The natural history of limb-threatening ischemia is markedly dissimilar from that of asymptomatic PAD or intermittent claudication. It includes an association with a rapid progression to limb loss. Disease typically involves multiple levels of the lower extremity arterial system, and while the exact amputation rate is variable, it's reported as high as between 15 and 40% within 1 year of symptom onset. Risk of limb loss is inversely proportional to ankle brachial index, or ABI, and essentially that in this one study was a double the risk associated with a cut point of an ABI of 0.5. There are also very high rates of mortality. These are predominantly associated with myocardial infarction and stroke. Estimated mortality rates amongst this group of patients at 1 year is as high as 25%, by 5 years up to 50%, and up to 70% by 10 years. It can be improved somewhat with medical therapy these days, including statins and antiplatelet agents, as well as risk factor modification and control. So, what does a classification system really offer beyond what a simple clinical diagnosis and ankle brachial index can do? And what's the rationale for having a Wi-Fi classification? Why not just use any of the many existing systems you see depicted on this slide here? Well, it turns out none of these systems is particularly comprehensive. They all use a single static cutoff value of ABI or TBI to determine adequacy of perfusion to the foot. So when leaders in vascular care got together to consider revising these classifications, they started by noting these limitations, as well as the failure to incorporate some other major clinically relevant factors. They had the following 2 primary goals. 1, to accurately stratify patients with respect to natural history of their disease, and 2, to provide sufficient granularity to compare different treatment strategies between patients. And as the name would imply, the system incorporates 3 major factors: wound, ischemia, and the presence of infection. Each is graded on a 0 to 3 scale, with 0 being the least severe and 3 being the most severe. A couple of words about wound and the importance of including wound in Wi-Fi. Neither the Rutherford nor the Fontaine systems incorporated any details about wounds. So the goal of Wi-Fi had to include to factor in wound characteristics as well as the complexity of needed procedures to achieve wound healing. The wound classifications themselves, again, ranged between 0 and 3, with 0 being no ulcer, so that this could be used on patients with rest pain alone, up to 3, which is an extensive deep ulcer involving the forefoot and or midfoot, deep full thickness heel ulcer and or calcaneal involvement. Gangrene also can be categorized and then assigned accordingly, with extensive gangrene seen in the 3rd categorization here. It's important to also note that this categorization system does not include patients with advanced gangrene that the clinician believes precludes foot salvage, which again is somewhat of a limitation, but is important to note with this system. Ischemia. Commonly used diabetic foot ulcer classifications have a static ABI or TBI cutoff for their perfusion assessment. Multiple studies have shown that perfusion is actually a spectrum, though, not a static cut point. The Wi-Fi ischemia grading requires the use of either a toe brachial index or a TCPO2 in diabetic patients. And then the categories that result are as follows: 0 being an ABI of greater than 0.8, 1 an ABI between 6 and 0.79, 2 being an ABI between 0.4 and 0.59, and 3 being an ABI of less than or equal to 39. You'll see that these also have ankle systolic pressures or toe pressures that can be applied depending on the nature of the patient. And foot infection. So despite the fact that multiple trials have clearly demonstrated an association between infection and limb loss, almost all prior classification systems have ignored the role of infection. The Infectious Disease Society of America has a diabetic foot infection guideline, but it ignores other factors. So the Wi-Fi system intended to directly incorporate this IDSA categorization into a broader context. And this was how they ultimately defined foot infection. So again, 0 would be the absence of infection altogether, whereas grade 1 would be sort of a mild infection. So infection is present, defined by the presence of at least 2 of the following things, either swelling, erythema, warmth, or purulent drainage. Category 2 is a local infection with erythema greater than 2 centimeters or involving structures deeper than the skin and subcutaneous tissues, for example, the presence of an abscess or osteomyelitis, but no systemic inflammatory response. And then finally, grade 3, the most severe grade, would be a local infection with signs of SIRS as manifested by 2 or more of the following: either a fever, a heart rate greater than 90, a respiratory rate greater than 20, or a white blood cell count of greater than 12,000. So how does this all come together into a clinical application? Each patient receives a score in each category from 0 to 3 when they're initially identified and evaluated. So if we have this example of a 55-year-old gentleman with diabetes, dry gangrene of 2 toes, and a less than 2 centimeter rim of cellulitis at the base of those toes, but without systemic or metabolic toxicity, but no palpable pulses. ABI is 1.5, indicating non-compressibility, so the toe pressure instead would be used, and the toe pressure in this case is 35 millimeters of mercury. That patient would then fall into the classification on Wi-Fi of 221. So with all of these different possibilities for all of these different wound, foot, infection, and ischemia grades, there's a total of 64 possible clinical scenarios. And each of these was assigned to one of 4 clinical stages corresponding to risk of limb loss. It's important to note this was based on consensus of expert opinion. These clinical stages are then used to estimate an amputation risk and a benefit from revascularization. Again, it's important to note that there is such a thing as an unsalvageable foot, which would be considered clinical stage 5. And the SVS has actually launched a mobile app for calculating Wi-Fi scores. So you just see some screenshots I took here of this calculator. It also includes some information and some references for those who are interested. But essentially it makes it quite simple and straightforward to put these inputs about ulcer, gangrene, ABI, toe pressure, infection grade, etc. The result then is this this calculator that you get with this Wi-Fi score. In this case that I put in, it was 220, which puts the patient at a clinical stage of 3 at moderate risk for amputation, but at a high potential benefit from revascularization. So the Wi-Fi system has been validated. So it's important to note, as I said, this was based on expert opinion. But they've undertaken really extensive efforts to try to understand exactly how well it performs in clinical practice, to try to, on the back end, at least provide a lot of evidence and rigor to the methods. And you see here, this was a meta-analysis that was conducted in systematic review. And the pooled data for major amputation at 1 year corresponds very nicely. So in Wi-Fi grade 1, there would be a 0% risk of major amputation after 1 year. In Wi-Fi 2, an 8% risk. in Wi-Fi 3 an 11% risk, and in Wi-Fi 4 a 38% risk of major amputation after 1 year. Similarly, for amputation-free survival after 1 year, the pooled data gives a random effects of 83% for amputation-free survival in Wi-Fi 1, a 76% amputation-free survival in Wi-Fi 2, a 75% amputation-free survival in Wi-Fi 3, and a 55% amputation-free survival with Wi-Fi 4. So again, you see that this is a nice demonstration that this model is able to discriminate into categories pretty effectively. And of course, there's been all these publications to go along with that. So many different uses of the Wi-Fi have come into play here. You see utility of skin perfusion pressure values within the Wi-Fi classification system, and outcomes of severe limb ischemia with tissue loss, and impact of revascularization for dialysis patients with Wi-Fi stage 3. Sort of a whole laundry list of publications that have come out studying this scoring system. Nearly 100 articles as of the time of this August 2021 report. But so what? So is this just a research tool and a nice way to get all those publications out there? To really understand the role of Wi-Fi, it has to be considered in the context of the 2019 Global Vascular Guidelines that came out. So the 2019 Global Vascular Guidelines for CLTI was a consensus document from the Society of Vascular Surgery, the European Society for Vascular Surgery, and the World Federation of Vascular Societies. It consists of 113 recommendations, along with the Wi-Fi, glass, and planned methodologies, which I won't get into entirely, but I will at least touch upon. As I foreshadowed at the beginning, chronic limb-threatening ischemia, the authors began this report by acknowledging that previous terms of critical limb ischemia and severe ischemia are outdated. They instead recommended the term chronic limb-threatening ischemia. CLTI is defined as PAD with any of the following additional features: ischemic rest pain, diabetic foot ulcer present for greater than 2 weeks, or gangrene involving the lower leg or foot. It's important to note that it does exclude patients with traumatic wounds, acute ischemia, embolic disease, vasculitis, and venous ulceration. The guidelines recommend to use the Wi-Fi system to classify CLTI into 4 clinical stages. They recommend restaging at 1 and 6 month intervals post-treatment. They envision this to be used a bit like a TNM classification for cancer treatment, where patients have to periodically be restaged as their treatment progresses. All patients suspected of CLTI should get an ABI as their first screening test, and it should be a TBI instead if a patient has diabetes or wounds on their foot. This is all in the larger context of this plan framework that they report, an attempt to synthesize multiple factors to develop overall revascularization strategies individualized to each patient in terms of their risk of undergoing procedure, their Wi-Fi staging, and an anatomic pattern of disease, the glass system, which is far too complex for me to get into today. So, in summary, optimal use of Wi-Fi includes a consistent and repetitive protocol to alter treatment strategies, guide the need for reintervention, and monitor for reoccurrence in this very complex group of patients at such high risk for such bad outcomes. I do think it has a role. I think it will take time to get it incorporated into practice, but I do see its utility beyond the other classification systems previously described. Thank you for the opportunity to speak today.